All right, good morning, good afternoon, and good evening. Thanks to everyone who is joining. I know that we have some folks from Saudi Arabia and a few other countries, so thank you for joining. My name is Jody Rodney, and I am the Vice President of Marketing and Education for Plan Mecca USA. Today is the 6th in our webinar series, Plan Mecca Digital Mastery Series. With us today is Chad Wooters and Michael Cowen from Awaken2Sleep. Our topic today is Dental Sleep Medicine Team on Fire. Before we get started, I do have a few housekeeping items. One, all of our attendees are muted and we cannot see you, so there is no video function for attendees. If you experience any technical issues, please submit the issues via the chat function. If you have questions for Chad, please submit them via the Q&A function, and we will answer all questions at the end of his presentation, which we expect to take approximately 60 minutes. We are recording the webinar, and it'll be available on our registration page later today. Additionally, there will be a post-webinar CE survey via the chat function. Again, the CE survey, which will be available at the end of the presentation, will be posted in the chat function. You will need to complete the survey in order to get the CE verification. So without further ado, I'd like to introduce Chad Wooters. Chad, take it away.
Thank you so much, Jody. Good morning, guys. It is 8 a.m. here in sunny California. Not so sunny California, actually. We have lost our sun this week. Thanks to all the weather. So I hope you guys are doing well in your different areas. Today, we're going to be talking about dental sleep medicine and how to start with the team on fire. We're going to go over quite a few different concepts. So my ask of you today is that you guys pay attention with the notebook and that you guys are looking for the things that you can apply into your office. Dental sleep medicine is a team-driven protocol that allows you to build a lot of cool and custom things into your practice. And so we're going to talk about how to start looking at that and the general workflow from a 10,000-foot perspective. If you miss anything I say, or if I talk too fast, please make sure to ask in the question and answer, and we can make sure to go back and review that. A couple of disclosures: Awaken2Sleep is a for-profit company. We do have services in the industry. We are bringing this today to you for free, and we're not trying to sell you anything. We're just trying to educate and share our passion as a company with you in the dental community. Additionally, we're gonna try and have some fun, and that should be a disclosure because I know you guys are on a lot of webinars right now. So if you guys can participate, I'm gonna try and have some interaction with you. I can't see you on video, but please make sure to comment, look at the chat, communicate with me as your speaker so we can engage. And then the last disclosure, or I guess rule for our webinar, is that there is no falling asleep in sleep training. It's the morning for some of you, and maybe you just got up and maybe you're in pajamas watching this webinar, but you are not allowed to fall asleep. If you're in a real class of ours, then we might actually throw a marker at you falling asleep. I just can't do that because it's digital and you're probably far away. So let's strap in and let's get started. And what we're going to do right now is we're going to share with you the story of what actually started our company. Every company has a strong why, or should have a strong why, and we hope you guys have a strong why. But we want to share with you a message from our CEO, Michael Cowen, and what it was that started Awaken2Sleep and the passion we have to go help change people as it relates to sleep and airway.
I have an 11-year-old daughter named Anna, and we almost lost Anna 10.5 years ago. You see, she was born with a condition called acid reflux that unknowingly caused obstructive sleep apnea. I'm Michael Cowen, founder of Awaken2Sleep, and it's my Anna's story and the people that invested in me, the knowledge that was given that impacted our family and her life. You see, it's our mission to give you the tools and resources necessary so that you can help your patients in the way that only you can. Come join us on this mission so that you can help your patients in a way you never thought possible.
All right, guys, so this is Mike and his family. Matthew, I see your question. If you could use the question and answer feature, I'll come back to their question at the end. This here is Mike's family. Mike is on the left-hand side. On the very right-hand side is the daughter that he spoke about. At 5 months old, she was diagnosed as severe apnea, and the hospital wanted her to wait 4.5 months to do an in-lab study. Something that Mike has brought into our company and we have as a culture here is that we are persistent. And Mike pursued getting that test from a friend of his who had his own sleep center borrowed some equipment from the hospital he was working at as a sleep tech 16 years ago. And he got his daughter tested, and the pediatric doctor said, if you had waited for that test from the stat referral that you got from the hospital you worked at, your daughter may not be here today. We have an amazing story to share. We have an awesome story to share in that we have a successful case. But the reality is that there are a significant amount of families out there today that do not have that story. There are people out there who are suffering, whether it be adults or children who have sleep apnea or other airway disorders that are suffering unknowingly. Part of the reason I love what I do is because I actually have a similar story. I'm not exactly your stereotypical apneic. I've only gained weight since my diagnosis, ironically. I'm healthy weight, you know, going to the gym, all that jazz. But I escaped the radar. I escaped the medical community and the dental community. No one talked to me about sleep. In fact, people advised me to not take a home sleep study or take a test because look at me. Part of my why is that for me, it's a very real thing. I went from being a moderate apneic, having 22 events per hour where I stopped breathing or almost stopped breathing, and treated completely. Now, I was first with an oral appliance and then surgery, so I don't require an oral appliance at this point in time, but we'll talk more about that journey a little bit. A couple other parts of my why. On the left-hand side, you have my niece and nephew. On the right-hand side, you have some of my siblings. They're actually a little bit older now. This is the best picture of all three of them I could get into one shot. And in the middle, you have my bride-to-be, who's going to be getting married to me. Lucky her, half kidding, until on August 1st. And you know, recently we actually developed that story too. After months and months of pestering her because she's chronically tired, we actually learned that she is also mildly apneic. And so when I talk about sleep, when I talk about sleep apnea, it changed my life. You know, going from being tired every single day to wanting to go climb a mountain after treatment, to having my fiance, who now we understand why she's chronically tired. So one of the questions we want to ask you as we go into this topic of sleep. Sleep is an auxiliary service. It's something you can provide, but don't have to in dentistry. But why would you do that? Why are you going into your dental practice and looking at offering this amazing service? For people like me, for my fiance, Michael and his family, this service could save their life. Whether you're getting involved in kids or adults, you probably know someone in your practice or your family or your friends that are suffering from this condition unknowingly. So we're going to talk about the need for this in our community. And as we get started and giving you a glimpse of what sleep apnea is, I also got to say this, there's a lot to be taught on this topic, tons. What we're going to try and do today is we're going to leave you with actionable steps and data and information you can use. So as much as I'm going to go into some of the clinical, a lot of our focus today is actually going to be giving you the verbiage to communicate with normal people. If you're on this call and you're a doctor, then you're probably like me and you love to talk technical. Some people think that the way I talk when I present to doctors is different than how I talk to normal people. It's actually not. But I've found I've had to shift the way I talk to normal people because some people get lost when I start using big words, right? So we're going to talk about how to talk about scary concepts and definitions and bring them to a patient level today. So if you want me to go over anything in more clinical detail, please comment. I'll be happy to review that detail with you, but we're going to focus on what you can take in your practice or take in your conversations really after the end of this 1 hour. First, we thought we'd start off with something extremely exciting in definitions. Definitions are critical as it relates to any new clinical thing we're investigating. So here, we're going to talk about the diagnostic criteria for sleep apnea. We're going to get to the levels of severity a little bit later, but the diagnostic criteria and how we gauge what patients have what. So in apnea is a reduction of airflow for 90% for 10 seconds or longer. When I talk to patients, I tell them this is when they stop breathing, or very nearly so, for at least 10 seconds. A hypopnea is a reduction of airflow of 30% with an associated 4% drop in blood oxygen level. When I talk to patients, I say, this is when you almost stop breathing for at least 10 seconds or longer. One thing that's important to note about both of these definitions, it's 10 seconds or longer. As someone's apnea increases in its severity or as they continue to live with this condition over time, these events can last way longer. I mean, in some cases, over a minute. Now, those are extremely severe cases, but these events are just starting at 10 seconds, and then they get longer over time as their condition worsens. The next definition to look at is our apnea-hypopnea index, or AHI. It's a total number of apneas and hypopneas divided by the hours we slept in a night. This is often what's referred to as a sleep score. So if you ever see a patient and they say, well, I did a test and my sleep score was, that's typically what they're referring to, their AHI. It is one of the criteria used to diagnose a patient and their level of severity of apnea. The next number, it could also be what they refer to when they refer to their sleep score, and by the FDA's guidelines is also one of the criteria to diagnose a patient. It's called the Respiratory Disturbance Index. It is our AHI and what's called a RERA, averaged out over the amount of time that we slept. A RERA is a respiratory effort-related arousal. Say that one more time for you. A respiratory effort-related arousal. Basically, in this, our body is waking up while we're sleeping. This could be caused by snoring, could be caused by noise, it could be caused by upper airway resistance syndrome, or just a increased pressure or difficulty in breathing. Our heart rate spikes, we lose our sleep, we wake up even slightly, even if we don't remember it, and we're waking up. The reason that RDI is considered as one of the diagnostic measurements here is because sleep in our health is not just dictated by the amount of sleep that we get, but the quality of sleep that we get. In apnea, we have a lot more events, and we're going to talk about those events and as relates to our heart and things like that in just a little bit here. But in the RDI and why those events matter, we're talking about events that are waking us up and stopping us from entering that restorative cycle of sleep that we need for proper sleep and recovery. So those are some definitions. When we talk to patients, when we're talking about breathing, it's going to be really important. One other shift I'm going to have, and I'm going to start doing this right now, is I'm not going to be talking about sleep apnea until we get to definitions and we start getting to the treatment protocol. We're going to start talking about airway health. See, everyone has an airway. And when you talk about airway health, they don't get triggered by that article they read in 2013 that said if you're not this big and you don't have this size neck, then you probably don't have sleep apnea, because everyone is self-diagnosed non-apneic, even me originally. So here, when someone's breathing healthy, we want to look at their airway. First, when we're sleeping, we typically want to breathe through our nose so that we clean the air and moisten it. That way it goes down our throat pretty well and enters our lungs in a prime condition. We can also see that some air passes through the throat and that there's a very clear airway available to us. When we talk about someone who's snoring, snoring is by definition a partial collapse. It's when the pharyngeal tissue in the back of the throat starts vibrating. I don't know about you, but when I was a kid, we used to take these blades of grass and put them together and put them to our lips and blow. And when we did that, there would be a thumbing noise or a humming noise. Here, when we talk about snoring, it's the same mechanism that works there. When we snore, our tissue vibrates in the back of our throat, causing noise to come out. And depending on the longevity of the snoring and the loudness of the snoring, that's going to be dictated by the patient's anatomy. So when we look at that, that is snoring, and that's also why snoring is such an indicator of sleep apnea typically, because if snoring is to get worse, then it can lead to an obstruction. As we can see here, this patient's airway is obstructed almost completely, if not 90% or more. And the reason this occurs is, as you've noticed, all the soft tissue, the tongue and a couple of other structures have expanded. When we go to sleep, our body falls asleep. Our skeletal musculature actually goes into a state called atonia. At Awaken2Sleep, we call it a tonic state. That muscle expands because it goes to sleep, just like the rest of our body. In order to relieve the obstruction, typically our body is going to wake up and pull the jaw forward, or a number of other mechanisms it uses. Just waking up alone is actually helpful because it brings tension and tone into those muscles. So this is a collapsed airway, and we see that when these events happen at a certain frequency, we can diagnose a patient with obstructive sleep apnea. So those are some of the basics of airway and what it looks like. One other basic of airway is called Bernoulli's principle. Now, Bernoulli's principle was originally a law of fluid and aerodynamics. Today, we're going to talk to you as relates to in and out shakes. Now, as a California, we have a couple redeeming factors for our state, but one of them is that we have in and outs. In and outs are kind of one of our prized possession next to our beaches. They are fantastic. One of the things on their secret menu is this Neapolitan shake. Now, in and out shakes are kind of like some of the shakes that you guys have in your different areas. They are made with real ice cream. So when you get this milkshake, it is solid. I mean, you can grab that spoon and the whole thing will come out. You can drop it upside down and it won't come out because it's super solid. When you first get that milkshake though, everyone's tendency is to get the milkshake, and the first thing that we do, even though the same thing's gonna happen every time, is we grab that straw and we take a big sip. But what happens? Absolutely nothing. When we draw that breath, when we try and suck in that milkshake, it's solid ice cream at the bottom, so nothing happens. But there is something that happens to the straw. Typically, we'll see that the straw collapses. So at that point, how do we get ice cream? Well, we're trying to figure out we want to drink this milkshake, right? So what do? Well, we have two options. First, we can stop sucking, novel concept, or we can pull the straw out and pinch the end of it to open it and put it back in and suck through the straw again to try and hold it open and patent. How does this relate to sleep apnea? Pretty simply, if we flip this milkshake upside down, then it actually looks like the dynamic of our lungs pulling on the straw of our throat. When there's an obstruction or nothing can pass through the top of our throat, our airway acts like that straw and collapses. This is explained by Bernoulli's principle, which describes the lack of pressure or the decrease in pressure, which causes a system to collapse in this instance. In order for our body to open up that airway, it has a couple choices. One, it can pinch the end of the straw. This is typically done by waking up, moving the mandible forward, or a couple other mechanisms, just waking up in general, like I mentioned earlier. The other alternative is to stop breathing. If we stop breathing, what happens? We die, we pass away, which is why sleep apnea can be a life-threatening condition, because over time, as your body gets worn out, it may accidentally stop breathing. Our body's gonna do everything in our power to make sure that doesn't happen, but it is a possibility. So I hope when you see your next milkshake, whether it be real ice cream or not, that you think about Bernoulli's principle in that straw collapsing. One of the tools that we want to give you guys today is a breathing exercise, and it relates to Bernoulli's principle. Now, before we go through this breathing exercise, I do have to have a disclaimer as well. If you have any heart conditions or any medical history that require you to not extend yourself, increase your heart rate, or decrease your airflow, please excuse yourself from participating from this exercise. It can be dangerous if you do have a heart condition. So what we're gonna do, and I'm not gonna spend a whole lot of time on it because it's, typically we got other stuff to talk about, right? So here, what we're gonna do is pretty simple. You're gonna plug your nose, you're gonna close your lips, and you're gonna take 3 deep breaths in. Now, I'm gonna show you what that looks like. It can be a little tricky. Some of you are thinking, well, Chad, my nose is plugged and my mouth is plugged or closed. I can't take any breaths. I'm aware that's how the exercise works. That's the point of the exercise. When we talk about this exercise, it is actually an exercise done by ENTs, except for one difference. They typically shove a camera up your nose and look at your airway, and they try and identify the point of collapse in an airway. If you've done this right, then you'll typically feel a pressure located somewhere in the base of your throat. So I'm gonna demonstrate what that looks like and give you 1 or 2 tips that help me do this exercise correctly. So let me demonstrate and then give you tips. So plug your nose, close your lips. Excuse me, sorry, my face is gonna go red for a second. Gotta take a breath. Uncomfortable right behind, for me, it's right behind my Adam's apple. For you, when you're doing this, if you can't simulate that collapse, if your ears don't pop, then what I had to do originally was I had to just physically pretend like I was breathing, moving my chest back and forth. You saw me heavily breathing in and out. The other thing you can do is try sucking down with your jaw muscles. You're trying to get your brain to do something that it knows it shouldn't be doing. If you do this, you will feel that uncomfortable pressure, and that is what an apnea feels like. Now, as we get into these definitions, you'll note that if that's what an apnea feels like once, and it's uncomfortable, it causes your face to flush red, you're short of breath, you feel kind of anxiety because what happens when we do start suffocating is we have hormones that are released that are causing anxiety, and our fight or flight response is triggered. So if you're like, oh my goodness, I gotta move, that's natural, it's okay. That's part of the breathing exercise. That was once, and you probably didn't make it 10 seconds. When we talk about patients who come in here and they're diagnosed with obstructive sleep apnea, what's happening to that patient is that is happening at least 5 times an hour for at least 10 seconds or longer. Every night while they sleep, probably. So let's talk about those definitions, and we'll come back to that point earlier about how that must feel. Even if the patient is not remembering it, how does it feel? A patient who's considered normal, they don't have any kind of condition, has less than 5 events per hour. Typically, their O2 saturation is going to be more than 90% in this on an average basis, but they have less than 5 events per hour. When I talk to a patient, I say, well, congratulations, you're normal. You stop breathing or almost stop breathing less than 5 times an hour. Now, there might be an issue with breathing, up to 5, but that's what the clinical guidelines are. A mild and moderate patients, we're going to group those together, and I'll come back as to why. is 5 to 15 events per hour. So 5 to 14.9, someone is considered mild. 90 to 86% oxygen saturation. And then moderate is 15 to 29.9 events per hour. Great question, Richard. Brandon, I'm going to come back and Branton, I'm going to come back and answer that on the slide since it's relevant. So when we talk about mild to moderate patients who are adults, thank you for clarifying. Mild to moderate patients, by the FDA's guidelines, can actually choose a dual alternative for primary treatment. That can be an oral plant manufactured and administered by a dentist, or it can be a CPAP. That is the guidelines for the first line of treatment for mild to moderate patients. Now, there's a couple of factors to consider. We have to consider if the patient is eligible. We have to consider if they're recommended by a physician to take that step forward. And then on top of that, they've got to find a dentist to work with them, and they have to want it. If the patient truly wants a CPAP first, then we should honor that. The next level of severity is more than 30 events per hour for at least 10 seconds or longer. Severe patients' primary recommendation is always going to be CPAP. If they're intolerant or refuse CPAP, then there is an option for them to pursue oral appliance therapy, either in combination with CPAP or independently. As relates to children, we don't have that slide on here, but children do have different measurements for their levels of severity. The main reason for this is because children going through development have to have sleep and oxygen for their bodies to develop properly. When we start depriving the body of sleep and oxygen, especially as children, we start to see repercussions as it relates to their cognitive function, as well as, but not limited to, how their body heals and how sick they are, snoring. Symptoms like ADHD can present themselves. So we actually lower the bar. What I mean by that is, if you have 5 events as a child, I believe you're moderate or severe. We have an entire part of our company that works with children. We are extremely passionate about children, especially with the story we shared with you earlier. So if you have kids who are presenting some of the signs and symptoms here, make sure that you communicate that to their parents and refer them out. Or if you have a home sleep study or have a place you work with to test them, pursue getting them tested. There are home sleep studies that are used to diagnose children in the marketplace today. We'll come back to more questions on children later if you guys have them. All righty, health impact. So we've now talked about what sleep apnea is, how it works from a mechanics function, and really what an obstruction is. We've talked about the clinical levels of severity, but why does it matter? How does sleep apnea and obstruction or airway really impact our patients? Check out this study done by Resmed in 2011. I want to point out 4 big stats to you. Now I encourage you, take a picture of this for your records, check it out. But the big 4 I want to point out to you, starting from the bottom and going up. 1, all hypertension. 37% of patients who have any type of hypertension also had obstructive sleep apnea. If you look at type 2 diabetes, 72% of patients who suffer from type 2 diabetes also had obstructive sleep apnea. 77% of those with obesity also had obstructive sleep apnea, and 83% of patients with drug-resistant hypertension, patients who take 2 or more medications to manage their high blood pressure, also have obstructive sleep apnea. Now, this is not corresponding to causal factors. We're not talking about, hypertension or sleep apnea causing these things. This study is just evaluating the presence of one medical condition with the other. Here's my question to you. How many patients do you know in your dental practice have drug-resistant hypertension alone? If you can find 10 of those patients, statistically speaking, 8 out of 10 of them probably have an airway issue. 8 out of 10 of them probably have obstructive sleep apnea. If you can combine any 2 of these, and you're looking at an over 50% chance that that patient may be suffering from a life-threatening condition. The question that we're not prepared to answer, but we are prepared to ask is, what is causing sleep apnea and what is causing these comorbidities? If a significant amount of strain is introduced on the heart and our system every night because we're choking in our sleep 5 to 30 times an hour or even more, could that have cardiac repercussions? Could it have repercussions on our hormones and how we process food and chemicals at the end of our day? It can impact those things, but whether it causes these conditions is not a question we can answer today, just a question I'd like to pose to you. This is some of the ways it can impact people. Additionally, let's look at the need. This is for America. I know we've got some international audience here, so your statistics I don't have, unfortunately, but just in America, in 2012, it was estimated that there are over 30 million Americans who are suffering from obstructive sleep apnea, over which, if I've got my math correct here, 90% of them unknowingly. Only 10% of that population has been diagnosed. And of the 10% that's been treated, 25% have been successfully treated. So we've got 10% that know they have an issue, and 25% of those people who are treated. There's a significant need in the industry, in our country, in your community, to diagnose patients, and you're not diagnosing as a dentist, so let me rephrase that, to identify patients who may be at risk for obstructive sleep apnea and start the conversation. As it relates to treatment, you guys can treat patients with oral appliance therapy if you have that recommendation from a physician. And we're going to get talking about how people are treated and clinical guidelines for treatment in just a little bit here. But when we look at this, there's so many people that need your help. How many people in your community or your town or your dental practice already are sitting there suffering every night unknowingly? So when we talk about getting involved, this is part of the reason for that. I was part of the 30 million. I was not statistically or stereotyped as someone who should have apneic condition. And I would have lost 7 to 10 years of my life as a moderate apneic because no one talked to me about it, because no one was willing to see the obvious signs and symptoms. And we'll get to those in just a second. Additionally, when we look at how it's affecting your country, on the left, we have a graph from the CDC that shares the lack of sleep or an increased amount of sleep deprivation by state in the United States. On the right-hand side, I'm going to show you a couple graphs. The first one is heart disease. Man, too early here for California. Sorry, I had enough coffee. Heart disease death rates in adults. When you look at these graphs, do you see your county on here? Do you see your state on here? And do you see a relationship between this? This is called an indirect correlation. These studies were not done to be compared, but when we put them over each other, we can see similarities appear. So do you see yours? And does that make sense to what you see in your dental practice? We look at stroke, and we start to see that if the brain has hormones released on a regular basis and it doesn't get what it needs to do its restorative process in the night because we're woken up, maybe there is cognitive and impact on our brain and neurological function. And also a diagnosis of diabetes. When we look at these graphs, and as we've learned about sleep, and again, we're looking at a 10,000-foot view here, it shouldn't be a surprise that these statistics are showing to be indirectly correlated. It starts to make much more sense. So when we talk about how we get involved with patients, some of the complications are on this graph. Please take a picture of this slide. This slide is it's pretty powerful. Most of these are great conversation starters. I'm gonna let you figure out which ones aren't. I trust your judgment. Now, that being said, if you were to pick any 2 of these conditions, then you have a greater than 50% chance that that patient is suffering from some kind of sleep or airway condition. So when you look at this, who do you know that is suffering from these things? Who do you see on a daily basis that complains of fatigue or drowsiness? Who do you know? If you can start the conversation with 5 or 10 people, then you've impacted 5 or 10 people in a way that from this conversation you've learned in just under 30 minutes. So it impacts our health, but how does it impact us socially? When we talk about the effects of snoring on the body, we start to see that sounds in general are measured in decibels. When a decibel, when it jumps up by 10, actually doubles in the loudness that it presents itself in. When you talk about snoring and its impact on marriages and relationships, how loud is a snore? Depending on the study you read, snores range from 60 decibels all the way up into 90 decibels. The loudest snore that we've ever heard of, and then we know has been recorded, it was 116 decibels from a little 110 woman in 110 pounds, ooh, mix my words there, 110 pound woman in New England. So when you check out her story, it's pretty crazy. 116 decibels, as loud as an airplane. So if you think about spouses who get upset about their husbands or wives snoring, if I slept next to an alarm clock, I'd have an issue too, because that's what I use to wake up. And if someone's waking me up a couple times an hour or for long durations when I sleep, that would probably frustrate me. Now, we are not recommending tasio therapy as a solution for treating sleep apnea. However, it technically would resolve the apnea in that one moment. Please don't try this at home. Laugh and the whole world laughs with you, snore, and you sleep alone. On that basis, just for married couples, it's estimated that 25% of couples in the US are sleeping apart. When you look at that, now I'm about to get married, right? So I have a personal connect to this. I'm pretty confident that one of the perks of getting married is that we get to share our living space, right? And I'm guessing that if we like each other, then sharing a bed's a whole part of the equation. So if I'm getting married, I don't want to be with the statistic. So why is this statistic so large? Why is this impacting so many marriages out there? So pretty substantial part of the equation here. It's impacting our patients every single day. So one of the other things that's kind of funny is our custom new home build. One of the most commonly requested features as it relates to a custom new home is 2 master bedrooms. If you look at this diagram, the master bedrooms are as far apart as they can physically be. And why is that? Either they love their guests that much, or someone snores like a freight train and they needed a couple walls and some insulation between them. So pretty interesting question that we can start posing, and understanding that it's really about who you know. As you start exploring your dental sleep medicine program, or this process and how you're offering it to your patients and your friends and family, start with who you know first. Believe it or not, there's going to be a significant amount of people in your immediate circle that probably have this condition. As a dentist, you are uniquely qualified to have a lasting impact in that patient's life by identifying them, potentially testing them, and treating them with a modality of treatment that is more widely accepted and used by patients. So getting started on that, before I start going about how awesome oral appliance therapy is and its role, well, let's talk about the total dance. Dental sleep medicine is a medical service that you can offer as a dental provider, but there's a couple hoops to jump through. So what does that look like? First, let's look at the overall process. First, we have to identify those patients who are at risk. Let me re-say that for you. We are identifying patients who are at risk. As a dentist, it is not within our scope to diagnose patients with a sleep condition. That requires a license of a board-certified sleep doctor to read and diagnose those patients. As a dentist in most states, I believe 47 states, you can own and operate your own equipment, or you can refer out to a third party. And in most states, I believe you can actually refer out to any type of medical facility for further testing as well. So we're going to get that patient tested. If you own and operate equipment, you're going to submit results to a physician to have those interpreted. If you don't own and operate equipment, you can refer them to a sleep lab or use a third-party service where they will ship the test directly to the patient. And if they're a good service, they will typically send those results right back to you with the recommendations, the diagnosis, and potentially a letter of medical necessity, maybe even an RX. And treat those patients based on the level of severity and the recommendations and the patient's preference. So when it comes to treatment, we're not going to get too much into that protocol because a lot of that is actually your dental training and you're a dentist. So I'm not going to try and teach you something that you can figure out super easily on your own. And there's a lot more topic and time that we would need to go into that in detail. But let's go through a couple parts of this process. Identifying those who are at risk. First, when we talk about this process, know this and the rest of the protocol that we talk about is going to be a team-driven workflow. Specifically as it relates to screening though, doctors, you should make sure that you are empowering your team to make a difference and start that conversation. Front office plays a role. Dental assistants and hygienists play a role. And doctors, you have a role to play, but it shouldn't be as the only one who is spearheading this campaign. If you're the only one spearheading this campaign, I salute you and welcome to the cause. But know that your team might be itching for something new. Your team, if they're empowered with the education, can absolutely have a significant impact on those patients themselves. And you can come in as a pinch hitter. So let's look at one of the forms that our front office can be involved in, or that can be done in the hygiene chair, depending on your workflow. Real quick, take a picture. What I need you guys to do now is comment your score. So I'm going to talk about it for just a second, but the way that this works, oh, that's me. It's my standing desk, guys. Sorry if I bump it or hit the arrow, it shakes. Sorry about that. So here, when you have your screening assessments, make sure the question is a yes or a no. So no excuses. If it's yes for any reason, then the answer is yes. Have you ever been told that you stop breathing while you sleep? Well, yes, but you know, I'm pretty confident I had a couple of drinks at that. No, the answer is yes. So mark it as yes. If you mark yes to any of these questions, then you circle the number next to it or add that to your total. At the very end, add up your total points, comment your points in the chat so I can see them. I'll tell you my score and I hope you guys can share yours. And this might be a little surprising to you. You might find that you're at moderate or high or even severe risk for sleep apnea. Cindy, you're a very healthy person. Thank you for sharing your score of 3. So when we look at these questions, the thing I love about this questionnaire is that it doesn't allow for patient excuses. Every symptom has an excuse. I'm sure you've experienced this in your dental practice, but this allows those to go away. My score personally was 39. So this one assessment would have helped identify me as someone who should take home a home sleep study. All right, moving on, guys, take a picture. When you come back to it later, we can. Another screening thing we can look at is, or tool we can look at, is the intraoral exam. First and foremost, we want to start talking about obstruction as it relates to the airway. When you guys are looking at a patient's mouth, and part of the reason that as a dentist you have a unique opportunity is that you are specialized in the mouth. When you look in the mouth, you can actually see the start of the airway, where a significant amount of the issues happen for patients who have obstructive sleep apnea. So 1, if we have large tonsils, 2, if we have an enlarged tongue, or we have 3, an elongated uvula, those can be indicators of an airway issue. If we plug up the front of the hose, then air can't pass through. So what could be causing an obstruction? The first thing to note is there, crowding going on with the soft tissue structures in our mouth? The next evaluation tool we want to share with you is the Mallampati. The Mallampati was an ENT evaluation used to help with, anesthesiologist evaluation, used to help determine the risk of someone going into or collapsing their airway during surgeries and being put under. It's put into 2 different groups of classification. Class 1 and 2 patients are considered to not be at risk, while class 3 and 4 patients are considered moderate risk for obstructive sleep apnea. The way that we do this is we have the patient sit upright in their chair, stick out their tongue, and not say ah. That's very important. We're not checking for infection in the back of the throat. We're checking on the distance from the base of the tongue to the soft palate. Now, when I talk to our patients, what I'm going to tell them is I'm going to share with you what I tell them typically. In a class 1 patient, we can typically see there's air or there's space all around the uvula. You can very clearly see around the entire uvula. A class 2 patient, we can see the sides of the uvula and a significant amount of the uvula. Those patients are not usually at risk or severely at risk with this one screening assessment. Class 3, we can barely see the uvula. In class 4, we probably don't even see the soft palate. We're probably looking at the hard palate. So when I talk to patients, I just use that verbiage, keep it super simple. If you start talking about the distance from the base of the tongue to the top, you're gonna lose them. So keep it simple. When you do this, I highly recommend you have the patients get involved, take a picture on their phones, show them this image or an image like it, and say, which one do you think that you are? Hopefully they can match the picture to the closest description, but then if not, you have a chance to educate them and engage with them in a more meaningful way. So that is the Mallampati. I think there's a couple, if you missed my explanation, there are a couple of free resources online. Check out our YouTube channel. I think we teach it on there for free. So other things intraorally, ways that we can identify them from the hygiene chair specifically or in our recare chair. 1, macroglossia or enlarged tongue, acid reflux, bruxism, tongue scalloping, attrition, high vaulted hard palate, bicuspid extractions, tonsils, and red and inflamed tissue. I want to talk about one specifically right now, and that's acid reflux, because I always get questions about it. Acid reflux can be an indicator of obstructive sleep apnea because as we have apneic events, pressure is placed on the esophageal sphincter, which is a seal that covers the airway from the stomach valve and stops acid from leaking up our airway or our throat. When we have an apneic event, pressure is placed on that valve, and it's a soft tissue valve, so it's continually hit. It weakens. Acid crawls up the base of our neck and actually stains our tongue. So how do we know if our patient's tongue is stained because of acid reflux or because they were just thinking about us when they came in for their hygiene visit? Pretty simple. I recommend warning the patient, but that's completely at your preference. Let the patient know you're going to be scraping lightly the top of their tongue. If you don't, they're probably going to be surprised, so be prepared for that. Scrape lightly the top of their tongue. If residue comes off, then you know that patient was just thinking about you this morning when they went to Starbucks before that visit. If it is in fact stained, then you know that patient is having acid reflux. That staining is a result of acid that's on the tongue that has stained the tongue, typically a white or yellowish color. Okay, those are some intraoral signs. If you guys want more depth, we're going to do a webinar next Friday on screening intraorally. So join us on that as well. Assess. Now, we've now talked about those who are at risk for sleep apnea. We've identified those who are at risk, but what's next? We have to get them the right test. Now, keep in mind, there are over 90 plus disorders as it relates to sleep and airway. Sleep specifically, I apologize. When you talk about airway, 90% of patients who have any type of sleep disorder have obstructive sleep apnea. So your scope as a dental practitioner is to help treat patients who have obstructive sleep apnea. I don't think you want the patient who has REM behavior disorder and woke up in Walmart in their bathrobe at 2 a.m. with no memory of how they got there. And an oral appliance is not going to help that person. So when we talk about patients who have any kind of sleep condition, we are specifically talking about obstructive sleep apnea, which helps us shape the next question. The wrong question in dental practice to ask is, would you like to take home a test? You're a doctor, and I've got a little spiel about how I go to the doctor, and they don't care about my opinions or feelings. They just tell me what the next clinically appropriate step is. If you have a patient who's at risk for obstructive sleep apnea, the next clinically appropriate step is for them to do an in-lab study or a home sleep study. Now, home sleep studies have come a long way. They are required to be 90% lead-to-lead accurate to an in-lab study, and they have a specific scope of practice. They are designed to make sure they're diagnosing obstructive sleep apnea. So we'll talk about that in just a second here. But no, the question you should be asking is, would you rather do a test in the comfort of your own home, or would you like to do a test in a hospital? Not would you like, would you rather? Because for them, that's the next thing. And understand that it's a serious thing. If I'd gone untreated, like I said, 7 to 10 years of my life would have been wasted, potentially. So let's talk about the polysomnogram. Real quick first, it's the gold standard. Everyone knows about it. What happens is your patient gets a recommendation. They go into the sleep lab. They're strapped up to a bunch of wires, as many as 25 to 35 leads. They're plugged into a wall. They test for one night. They will typically come back with a diagnosis, and then the sleep center, oftentimes, not always, will have them come back and do a second night study to do titration for a CPAP as a primary recommendation for most mild, moderate, and severe patients. Then hopefully they can see their primary care physician to follow up in a couple months and see how the CPAP is working and if they're using it. That's the typical process. You guys, if you know anything about CPAPs, airway, or the way that model works, you're probably already spotting a couple of the things that don't always work out the way they're supposed to. But keep in mind, a polysomnogram is extremely comprehensive. It is going to go look at everything from eye movement, electrical signals, sleep cycles, brain waves, electrical signals in different parts of your body. It's going to look at breathing from an effort from your chest as well as your abdomen. So when we start to look at it, it's extremely comprehensive. But maybe it's too comprehensive for what we're looking for. If we're looking for obstructive sleep apnea, then maybe we need a test that is designed to just identify obstructive sleep apnea. And if there's something else going on, will indicate the need for further testing. And that's what a home sleep study does. That's what a home sleep study is. In a home sleep study, in most states, a dentist can be involved in this process as well. Patients are screened. They're identified as at risk. They take home a test, hopefully that night or within a couple nights. They sleep in the comfort of their own bed. If you're a dental practice who's using an efficient workflow, you could be seeing this patient in as little as 1 week, or if you're using a third-party shipping model, as little as 3 weeks, doing a treatment planning conversation, reviewing those home sleep study results that have been interpreted by a physician. And if clinically appropriate, they can be treated with an oral appliance. So a faster workflow, a reduced barrier to entry, a lower cost for patients, and outcomes that they'll use. When it comes to an HST, they have to have 4 required channels for them to be considered a diagnosable HST. They must have snore, airflow, effort belts, and pulse oximetry. Those are required. A unit like this one on the left-hand side will also have positional data and have some adaptations to be able to look at a couple different things. Allocyte one is just 1 unit, not an endorsement, just a unit that's available in the marketplace. So it has a couple extra little pieces that are available. But when you talk about home sleep studies, you do have other options. You can do the temperature, the airflow, and a bunch of other add-ons that are available, bruxism guards or bruxism raters as well. Some pretty cool stuff. So getting them tested is comprehensive, getting them tested is clinically appropriate, and is approved as a guideline. So HST report. When we get back to this home sleep study, what are we going to be doing? What are we going to be talking about? One thing that's important to note, and I've said this a couple times, please make sure that you are not interpreting sleep studies of any severity without talking to a physician. If you read a report, the last thing I would hate to hear happen is some doctor who has a report, they interpret it as not being worth talking about. They dismiss that patient, and the patient comes back with the lawyer and says, well, can you interpret that report? We don't want that to happen. So make sure, whoever your provider is, that you have those interpreted. This is one example of a couple documents. One is a cover sheet interpretation that's going to cover the diagnosis, the level of severity, the main contributing factors to that, and the primary recommendations. The second is our fact sheet, which if you want to have a patient have glazed over eyes, I highly recommend going over that middle one. And the last one that we included on most or all home sleep studies is the graph. Now, the graph, in my personal opinion, no matter what home sleep study you're using, is the most powerful treatment planning tool that exists. Reviewing that home sleep study in an effective way, you're looking at the ups and downs and saying, does this look like a healthy amount of sleep? Is going to connect to that patient way more than listing off the numbers on a number sheet. Check out our YouTube channel for more information on how to present that data to your patient. treating sleep apnea. When we talk about treatment, what's really awesome as a dentist is you have a unique opportunity here to investigate the best option from an oral appliance standpoint. Now, before I get into oral appliances, actually, I should start off with all of the options. So there's 4 treatment options that are available to any patient who has obstructive sleep apnea. The first one is surgery. The most complex, it's what I opted to do after an oral appliance treated me. There's tonsillectomies, there's UPPs. You can, move your mandible forward, do jaw surgery, reconstructive surgery. You can do, oh my gosh, there's so many surgeries. So go check out the surgeries that are available to your patients. They are options, but they're typically much more expensive, much more invasive, require time, and not all people are candidates or can receive surgery. The next option is a CPAP. We all know the common issues. There's a common story about CPAPs and the fact that there are a significant amount of patients who won't or can't wear a CPAP for one reason or another. But CPAPs are an option. Remember, for those severe patients, please encourage them to pursue CPAP, to really try it out to the best of their ability. And if they just can't do that, then we talk about oral appliance therapy. But CPAP is going to be the best because it is 100% effective when it is worn. The next option is oral appliance therapy, where we move the mandible forward using a device such as this. And the last option before I come back to oral appliance therapy is nothing. The patient can do nothing. It is the first thing that we want to take off the table for that patient. It is the simplest, but it's also the most expensive. You can lose 7 to 10 years of your life. You're diagnosed and you've got a life-threatening condition. The chronic conditions that will present themselves after an extended duration of having this condition will cost you more money than any of the treatments that we've mentioned before. So when you talk about oral appliances, we have a couple displayed here, and these ones are organized by the mechanism by which they work or are manufactured. So in the top left, that one is a milled appliance. The one on the bottom right is a 3D printed appliance, and they use different mechanisms to work. A lot of them will use bands or hinges to move the mandible forward. Some will use a hook in the front of the mouth that will also function in that way, and the dorsal fin appliances as well in the bottom left-hand corner. There's a number of appliances out there. Here's the deal. You need to get educated on the appliances that are available. Find your top 5 that work for patients of varying dentitions and use those top 5. Most appliances have labs that they are required to work with because in order for these appliances to be made, they must be made in an FDA approved lab. They can't be printed or made in an office. They can't be milled on something that you have physically in your office unless you are an approved lab by the FDA for oral appliance therapy. But these must be milled in specific labs. So contact the company that manufactures the appliance or markets it and say, hey, what lab would you like me to send this to? When you start treating a patient, we can start to gauge how effective that treatment is by using an app called SnoreLab. There's a number of snoring apps out there. Any one will do just fine. This one is cool because it talks about epic sounds. So if you have a patient who says, I don't have a sleep issue, this is a great tool to give them to say, well, I don't want to make a liar out of you, but you make epic noises in your sleep. Make sure the patients know that you're recording audio so that all audio is recorded during the night in which this app is on. So that can be helpful and avoid some awkward conversations. Additionally, as you treat them and looking at efficacy, if we have a pre-treatment snore lab and we have a post-treatment snore lab, we can compare the results and we can see objectively how that patient is responding to treatment from a noise output. There's a variety of tools that we can use to subjectively evaluate the patient, such as Epworth, which is an evaluation tool used to assess daytime sleepiness. So give it time, check out the results, and after we find that the patient has been effectively treated subjectively and as close as we can get to objectively, we're going to prove it objectively. When we talk about treating these patients, after they've been treated for some time and they're feeling better, we need to do another home sleep study or an in-lab study to evaluate the effectiveness of treatments. Effective guidelines for a patient who's mild to moderate is if their AHI reduces to less than 10 by most boards. A patient who is severe and treated with an oral appliance, effective therapy is considered any time that their AHI reduces by 50% or more. Now again, with CPAP, please make sure for severe patients that they're attempting CPAP first, but if they're intolerant, then it's an option. You're gonna do another home sleep study or a test. You're gonna make sure that's read by a physician, and that physician will give you their stamp of approval. That way, there's no liability to you as a practice. You are working under the guidance of a physician after diagnosis, and now the physician is saying that treatment has been effective. You're not liable to dental practice. You are providing durable medical equipment and maintaining the care of the oral cavity, as you are uniquely qualified to do. Alrighty. So that is the general workflow. When we talk about the workflow and how it affects your practice, there's a thousand more things we could talk about, and your practice is unique. So there's no one size fits all strategy. I went over 10,000 foot view so you can see the parts of it and see where they fit into your practice. But we want to help people, and we have to run a business. We're not charities, especially in this time when we open up. We want to make sure that we are gunning to make up that difference in production, that we are helping people and building our practice appropriately. So how does this service offering help our practice? The typical cost of an oral appliance therapy treatment, home sleep study, because you're going to be including the home sleep study in your fee for the treatment plan, hopefully. The exams, delivering that appliance, and the appliance fee of $500. You can give or take $50 on that fee. Most are below that. But $950 to offer that treatment to a patient. And when we talk about how they're going to pay us, we see that our appliances are being charged at $2,850 to $4,500 across the nation. So we want with $2,800 here to go on the low end. But if you have a home sleep study, if you have a cone beam, you don't need cone beam to do sleep, but if you have sleep, why wouldn't you have a cone beam? There's also additional software that can help as a screening tool and a communication tool for airway as relates to large field and midfield view cone beams. So some really cool stuff there. Ask your plan medical rep about that. But here, these are the income areas that we can make money from offering this treatment. And you stand to charge about $3,300 on the low end. Your net difference, if you can help 8 patients a month, is $19,000 in net production. Now, these numbers are not guesswork numbers. These numbers are actually based on statistics from practices that we work with on a regular basis. But a single doctor practice that is seeing has a couple hygiene chairs, 1 or 2, sees 128 patients a month. If you can screen 80% of those patients, then you'll test 50 of them. If you can test half of those patients who are screened as at risk, then you will diagnose 25 of, let's say you get 30 to test. Then you'll still diagnose 25. Because as a company that does interpretations, we have the data to support over 90% of patients who do a home sleep study out of a dental practice are actually diagnosed with a sleep condition. So if you only test 30% of the people you screen, then what you're talking about is 25 people who you can start the conversation with and potentially help. That is what translates to revenue. So we're helping people and we're making money. It's a good day for everyone. Let's talk about 2 clients. One is a client in Virginia who is a single doctor practice, a couple hygiene chairs, and this month they learned about Invisalign. So their sleep program kind of got put on the back burner. They kind of forgot about it, but they still screen 10% of their patients. Our client in Ohio was a 4-doctor practice. They have 35 staff members, 10,000 active patients, humongous practice, and they screened 83% of their patients. So the question we have for you is, who made more? The 1-doctor practice who screened 10%, or the 4-doctor practice that screened 80%? Believe it or not, it was a smaller practice. Because when it talk about dental sleep medicine, your process, your practice, and the way that you run things is going to be different from someone else. So here, what happened, the biggest difference was that when they screened patients, the big practice, when they screened patients, hygienists were on it. They were like white on rice. They had the conversation on lockdown. But when the doctor would come into the room, they wouldn't give the clinical recommendations the best way they could. They didn't want to be too pushy. And so they didn't let them know the next steps that they should be taking, the next clinically appropriate steps, and the 2 options that they have. So patients never tested. Their testing that month was less than 5%. While this other office, they only screened 10% of their patients, but they tested every single one. And out of those that they tested, when they got down, and here's the deal. This doctor, I know him personally, really great guy. I'm pretty confident he goes into the room and he looks at the patient and he says, yeah, so we're concerned that you're dying. You should do this test to make sure that we're wrong. Something like that that's over the top and blunt and crazy. But he came in and backed up his hygienist every single time, validated what they were saying, and that patient took home a test. And when they sat down and they found out that they had a life-threatening condition that they have now proof for, that a specialist has diagnosed, they had an amazing, this office on the right, their treatment plan acceptance was over 60% this month. Most months it was 60 to 70%. So when you look at this practice, and I just want to pose this question to you as a dentist or as a person in your practice, just know So the question first, then I'll come to the conclusion. The question is, what things do you need to implement and where do you need to implement them? Because your practice is unique. These practices are unique. They require different solutions. And in this one instance, this 1 month, they were able to be compared because the situation was remarkably similar. But most practices require a little bit of custom work. You need to sit down and take some time and see how sleep fits with your team. Look at how you need to train that team. Look at how you need to bring sleep in. What testing model makes sense for you? Questions that you need to do some research into and find out the answers to. And the reason these are important is because it really allows you to make a difference with your patients. When you start talking to patients about this life-threatening condition and you start to see the change that takes place in their lives, you start to see that patients who now see you are excited to go to the dentist because you literally changed how they wake up in the morning, their energy throughout their day, how they talk to their kids and their wife. You did that as a dentist because you started a conversation that was overlooked by the overwhelmed medical community. Now, it starts with the first step. So our first recommendation to you is to go figure out what you need to do to increase your knowledge and learning in this area. There's a number of companies out there that offer a variety of solutions. So make sure they get the one that fits for you. At this time, we want to also open it up for questions. And at the very end, after questions, we do have just a couple things to say. If you are interested in Cone Beam, talk to your plan medical rep and get connected. If you will have questions, we'll go from there. And then I have a small little offer for you guys at the end too. No heavy push, no dollars, I promise.
And this is just a reminder that the CE survey has been posted in the chat function. So please make sure that if you're looking for CE credits that you go to the bottom of the chat where the link has been posted. We will post it again if more comments come in. And the AGD code is 200.
Awesome, thank you.
Yep. All right, Chad, so I think we can start to dig in here a little bit to the Q&A. One question, I think it's a good one and an important one, but what separates you from the Vivos model?
Yeah, great question. I want to say that Vivos and we are actually very different companies. Vivos sells an entire business solution. So you're going to go to them, I think they're in the $60,000 range, and their plan is to come in and build you a program and help you out with medical billing and things of that nature. They're also going to give you access to a patented oral appliance that helps expand the maxilla potentially. I'm not completely familiar with all of that science, but they do all of that. It's $62,000. It's way more comprehensive. Not comprehensive, I'm sorry. They want to come in, really do things over with you. We're a lot different. One, we are actually a full service coaching company. So we do coaching and some training, but the reality is for us, we like to work with individual practices and sometimes groups of practices, but we're really about helping you find what works for you. We don't have a one size fits all approach, and we make sure that when we talk to you about sleep, we're going to make it work for your practice and help you figure out how to engage with your team and patients the best. We also have tons of clients who are Vivos clients as well. We have, because they don't always do home sleep testing. So we do home sleep testing. We work with Planmeca to retail home sleep testing equipment. And then we do interpretations. We do home sleep test shipping directly to patients. And we do online education as well. So we're a lot different. We don't compete with them. They're just a different company with a different approach. Yeah, thank you for your question.
Yeah, and just a reminder, please post the questions in the Q&A function and leave the chat function for the CE credit link. One question coming in from the chat feature is—
I started seeing those, yeah.
Exactly. Does insurance cover any of this for the patients?
Yeah, oh my gosh. So talk about poking a hornet's nest. So yes, insurance can cover almost everything in this process, actually. But here's my advice to you. Well, let me pose this question. If you were starting in implants and you were just trying to figure out how to place a single unit implant, would you also start trying to figure out how to build medical insurance at the same time? If the answer is no, as it typically is, then I'm going to recommend you treat dental sleep medicine the same way. So you can do medical insurance. It will cover the test in some instances, and it will cover the oral appliance therapy in some instances, but it's complicated and it creates complexity when reality is we need to make money and help people. So let's start making money and helping people, and then we'll worry about the medical billing when we have a successful business model. Medical billing is an amazing place to take your practice, and there's about 3 different workflows you can use that are without doing full-on medical billing that allow you to help prepare documentation or succeed on a fee-for-service basis with dental sleep medicine first. So it will cover it, but please note that it's not recommended typically for a starting practice because, you know, you're trying to build multiple parts of it and you just got to learn one thing at a time and grow your program. So thank you. Great question.
We had a couple questions about what your YouTube channel is.
Yeah. So I think if you just type in Awaken2Sleep, it'll pop up, but you can also type Awaken2Sleep education. We don't have like sales on there, but there are a couple free like how to do home sleep study and stuff like that is found on there. So I know I just skim over some of those things here. The dentist role explained by a couple of our doctors as well is on there. So check it out. We do release content regularly on there. Thank you for asking.
Yep. Another question about how they implement CBCT and what it shows.
Great question. Yeah. So cone beam plays an awesome role as it relates to sleep because you wouldn't do a cone beam because someone is showing signs of sleep apnea. You can't diagnose airway or sleep apnea based on a cone beam. You have to be asleep to diagnose sleep apnea. I know it's a crazy concept there, but it won't diagnose. But if you do, we're taking a cone beam for another instance, for example, maybe you can't figure out what's going on, or maybe it's practice for you to take a cone beam for new patients, whatever that is. You can typically see the airway with those mid to large field of view cone beams. And when you do that, softwares, especially like Planmeca software, allows you to isolate and measure the airway and find the narrowest point of constriction. And when you show a patient a picture of their airway that looks, you know, that big, and it's, you know, got a minimal cross section of 16, you know, millimeters. You work with millimeters all day long, so you're probably familiar with that's tiny. You can show them that. You can say, hey, I can't diagnose anything going on here, but I'm concerned you have an airway issue. You should take home a test, right? So it's a communication tool. Additionally, when you start talking about imaging, there are softwares out there that require an intraoral scan and a cone beam to actually do their appliances for approval. So the cone beam can be a really awesome thing to offer to your patients.
Great. There's another question from a pediatric dentist about how to implement this within their practice. They're used to doing some evaluation airway for oral sedation, but they're currently sending the patient to an ENT. Yeah.
Amazing question. So one, I would probably say get some more education on your role as a dentist treating sleep with kids. Sleep with kids is an entirely different topic. It's super awesome. One, I would probably recommend also considering getting a home sleep study. The Knox T3 unit is, as far as I know, one of the only units in the US that's approved for diagnosing children. There's a couple that are approved to screen children, but the diagnosis isn't exactly covered under those devices. Additionally, find healthcare providers in your area that are going to partner with you as it relates to pediatric airway. Pediatrics treatment plans are so awesome because you can actually prevent and resolve apnea as they develop. So there's so many awesome things to do that. Healthy Start is an amazing program for that as well. But definitely, if you're interested, I'll put you in touch with our CEO. He loves working with practices and kids because that is where our heart is. We love working with kids because it's, you know, we all have a relationship with Mike's daughter, Anna, and she's super cool and she's well. And so we want to help other families tell that same story. Awesome.
Right,
I think you guys, go ahead.
Yep, sorry. We have a couple questions about appliances. So do you have a recommendation for a temporary appliance if a patient is in the middle of comprehensive treatment?
Yeah, great question. So TAP makes a pretty decent one. They have a temporary appliance, and there was a Blue Pro, I believe, are the top 2 that I've seen. They're pretty easy. They're boil and bites. You just do them in the chair. And then you can do that to also test efficacy of treatment, make sure they have responders to therapy. And they're really cheap to make. So those can be viable options while they're doing other treatment, so that when they're done with treatment, you can move them into a temporary appliance and actually have data as to where their final resting position is.
Great. The next question about appliances is, after making the sleep apnea appliance from the dental lab, should the patient be tested with the appliance in place to see if it is effective? And if so, how often?
Great question. Yeah, so that's what we talked about earlier. There are, so there's an entire efficacy protocol that we can go into, but the short version is you're going to be evaluating that patient on a regular basis. So we recommend a 1, 2, 4 process. So it's, you see them 1 week later, 2 weeks later, and then every 4 weeks to evaluate subjectively what's going on. And then once that you start to see subjective improvements, then you can administer another test that evaluates objectively the efficacy of that test.
Great. Somebody asked about your upcoming webinar that you mentioned, where they can register for that. Is that one through Plan Mecca or one of our partners?
It's actually through us directly. So we can absolutely host it on Plan Mecca's server. It's next Friday, I think, on our social media. We'll partner with Plan Mecca and sharing the details with you guys and make sure that everyone on this list is invited, and because Plan Mecca can help sponsor it for sure. So that'll be not a problem. Yep.
Okay. How is this different from the AAFE and the STAT DDS program?
Yeah, each program has unique differences. We could go into a deep dive into each of those programs and talk about how that works. One thing I want to be super clear on is I'm not trying to sell you a program today. You know, we do have programs, I guess you could say, but the reality is that we're not going to walk in your doors and say, hey, here's our system, good luck. We talk to practices, we get to know them, and then we do a significant amount of live content. Even our online education, the call to action after every online course is, how does this fit in your practice? How do you want to shift this template that we've given you to fit into your practice? So I would say most trainings, that is the difference in this. So yeah, I hope that helps answer your question. There's a lot, I don't want to get on those rabbit trails. There's a lot more depth we can go into that.
All right. As an RDH in a FQHC Medicare and Medicaid, our majority of our patients, many have CPAP, but would have better outcome and compliance with oral appliance. Are these insurances paying? Yeah,
actually, there are guidelines for reimbursement for oral appliance therapy. Your reimbursement is going to be significantly less if you're in network. So just be mindful of that, but there are protocol and policies in place with those insurances. I would encourage you to call into the insurances and check their guidelines. Make sure that you have the appropriate steps done and then submit those claims. Additionally, we have actually worked with practices to help them do what's called an upgrade protocol, because Medicare only covers a specific couple appliances like the herps and the tap. So they're not patient favorites or doctor favorites all the time. So when we start talking about that, then they will cover up to a certain amount, and then you can make sure that they are upgrading to a better appliance and the difference is covered. And Medicare, I believe, allows for that as well. So they're called those guidelines. If you want additional assistance, I don't coach on medical billing typically, so I can also reach out to someone else as well. And we'll share a link also. That's part of our offer, actually, is to connect with a coach through Plan Mecca, because of Plan Mecca, actually. But I'll wait till we finish. Well, I guess you've posted a survey, so I'll just share this. If you have complicated questions like medical insurance, because of our partnership with Plan Mecca and the relationship we have with them, we have decided to open up our result calls to the public through Plan Mecca. We're going to be posting a link in the chat. And in this results call, you're going to get a couple of different action items for your team, next steps, understanding where you are, and the workflow that's going to work for you and your state and location. So if you guys are interested in that results call, we're going to post that in the chat to all the attendees. It's a link and it's free. So if you want
so those
to, please.
Links have been posted. Yeah, the calendar links for the consults, as well as the YouTube link, has been posted. It looks like Michael's keeping everybody up to date over there, so that's good.
I think he posted it to panelist only, so I'm gonna.
No, I think there was. Oh yeah, sorry. So, yeah,
that's okay.
We can get the Sid, if you can post the YouTube to all attendees too, that would be great.
Cool. Alrighty. What other questions? You guys are great questions. Thank you. This is awesome.
Are there cases that can be treated by dentists without consulting physicians?
So that's a great question. I would just say this: if you're looking to treat a medically diagnosed condition that requires a specialist to diagnose, then you would want to make sure that you're treating the right thing and that you're moving forward under the recommendation of a physician. So there are things you can do to treat sleep apnea or sleep-related or airway-related disorders, but you have to identify if you're comfortable with the liability of having the liability of treating this patient and the scope of their condition as it relates to your scope as a dentist. So I can't answer that question for you, but our recommendation corporately is that anytime you're treating anything with airway or sleep, you have recommendation from a physician and you move forward under their guidance and really request. So that if anything ever comes back to you, you're 100% covered. Your license isn't on the line because some other doctor diagnosed and recommended treatment. You were following the orders of some other physician. So you can, and there are things you can do, like orthodontic treatment would be specifically something that a lot of orthodontists can do. So there's things that you can do in there that can help, but just be careful. Are you doing orthodontic treatment for orthodontic purposes, or are you doing it for airway purposes? Just be careful, have a multidisciplinary approach in there.
Okay, and then we seem to have several questions kind of just about the process again. So if you could give your like minute elevator speech on what the process looks like with the Sleep Hero Network and the home sleep test, and then how you incorporate the MDs into it, I think we'll kill about 3 birds with 1 stone there.
I like that. Yeah, multiple birds, 1 stone. Yeah. So hey guys, so it's super simple. As a dentist, there's 2 paths for you. 1, you can own and operate your own equipment in most states. So check your state guidelines or ask a sleep coach will help you. But if you own and operate your own equipment, you can send the patient home that day with the test. They bring it back. You upload the results to a physician who interprets it, and you get the results back in a couple days. That's called an interpretation service. Lots of those available to them. Additionally, if you don't want to own and operate your equipment, you're not ready to make that financial commitment, then you can use a service like ours through our platform, Sleep Hero Network, which allows you to talk to the patient and basically collect all the information. That information includes an RX from you as a dentist and what's called a patient intake form. That is a credit card agreement for us to process a card on file. You submit those to our online platform. We ship the test directly to the patient. The patient tests for 2 nights. They send that test back to our facility. We submit those reports to a board certified sleep physician and send you as a referring provider the interpreted results and recommendations and letter of medical necessity if clinically appropriate. So recap, you've got buy and own and operate your own equipment, connect with your Patterson rep to your Plan Mecca rep to do that, or you can use a third-party shipping model like us to ship tests directly to a patient. Very low cost for you, a little slower on the workflow standpoint, about 3-week turnaround time, but still really great way to get involved. The cost of a home sleep study through Plan Mecca is $2,800, and the cost of a home sleep study, if you guys are using our third-party shipping service, the doctor cost is we do require what's called a basic membership, so it's a $47 a month commitment, and the test for the patient is $347. It includes everything, no extra fees. We don't do the whole nickel and diming things.
Yep, and there's because there are so many international attendees, can you just kind of give an update on where you guys currently support customers?
Yes, so yeah, thank you for the question. We are currently only in the US for our we're only in the US for our home sleep test shipping services. If you are international and you wish for your home sleep studies to be read by a board certified sleep physician in the US, we're happy to help you. Our online education is mostly US based, but it's not available in other languages. But if you understand English, which on your webinar you probably can, then you're welcome to jump onto that education as well.
Great. All right. A couple more questions about appliances, and then I think we can wrap it up. How about SomoDent oral appliance? Do you have any feedback on that?
Yeah, SomnoDent. I believe they just released a new one. I haven't gotten my hands on it yet. SomnoDent is one of the top manufacturers of oral appliances out there. Again, you're a dentist, and how that appliance affects your patient and their dentition is actually your scope of practice. We'll educate you on, how appliances work in different types of dentitions in general, but you have to formulate your own opinions. I can't tell you what appliance to pick because you're the dentist in the room. What is the difference between a snore guard and a sleep appliance? Great question. Do you need a sleep study to make a snore guard? Thank you for that question. So here's the deal, guys. If a patient is snoring, it could be indicative of a larger condition going on. So if you're educated and you know that there's probably something that's impacting their life, then you need to get them tested. If you treat a patient with a snore guard, by the way, the reason it's different from an oral appliance is it's a non-adjustable appliance, and oftentimes they can be made chairside. So they're typically a little bit more bulky, they're one piece, and they just hold the mandible forward in a set position. They actually, in some studies, have been shown to increase apnea, similar to bruxism guards. And on top of that, It can resolve snoring, but since the apnea isn't treated, we create what we've called silent apneics. So a snore guard in an apneic patient will actually help this patient go unnoticed by the medical and dental community even longer, because now they don't snore. So you can technically, if you're not testing them, but you can't treat a diagnosed patient with a oral appliance who's been diagnosed. An oral appliance has a couple criteria to be considered an oral appliance, or what the FDA calls a mandibular advancement device. It must be custom fabricated and adjustable. It must be manufactured in an FDA approved lab. And the device itself must have met FDA approval guidelines and been approved. So there's a couple differences there. They're typically two separate pieces that interlock or interact in some way, whether it be a hinge or a fin or a piece in the middle or bands, whatever it is, and they adjust and are able to be moved forward or back and sometimes vertically to account for the patient. It would be our recommendation that you test all patients who present snoring as symptoms before treating them, because I would never want to, treat someone with a snore guard knowing that I possibly treated the wrong thing, and it worsened their condition. Bruxism guards are the same way, by the way. There's a variety of studies that show bruxism guards can actually increase the level of apnea in a patient. So before making any guard, we recommend testing that patient to evaluate if there's an airway issue so that you know how to move forward best. If they have bruxism and sleep apnea, then you get a dual rated appliance. If they have bruxism, give them bruxism guard. If they have snoring, only snoring, then you can make them an oral appliance or a snore guard. And if they have just sleep apnea, then they need to pursue the medical treatment that's recommended. That'd be an oral appliance or a CPAP.
All right, I think that wraps up our questions. Thank you all for joining, and for those who stuck with us to the very end there. Chad and Michael, thank you for your support. And if are there any other comments from you, Chad, before we close it out?
Just one, and I think we talked about it. Please, guys, if you're interested and you want to know more specific things, use that to schedule your free results call. We just want to be a resource for you guys, especially in this time. So thank you so much for your time. It's been a pleasure getting to hang out with you guys today.
All right, thank you so much, and thanks for those of you who joined. Have a great day.